Dear doctors in France and members of the Spectrum Group. I, Dr. Shrikant K. welcome all of you to this CME this evening on modern concepts in the management of knee and hip arthritis. And I've added a new caveat to this, a concept called GIRFT, which is a new concept in India, but quite an old concept introduced by Professor Tim Briggs, Professor of Orthopedic Surgery in London, around 2013. That is, get it right first time. For those who do not know me, I'm Dr. Shrikant K. consultant knee and hip surgeon. These are my qualifications. Particularly proud to have worked in Wrightington Hospital, UK, the birthplace of joint replacement surgery. As formerly a consultant in trauma and joint replacement surgery in the UK, at present I am proprietor and MD of Sarthi Specialty Knee and Hip Center at Govipuram, Bangalore. I'm also consultant in cohort of corporate hospitals in Bangalore. This is my website, shrikantk.com, and today is an auspicious day and auspicious week because we, as orthopedic surgeons in India, celebrate a bone and joint week, and today is the last day of the week. So happy bone and joint week to all of you. Before I introduce myself further, I would like to elaborate that today is the last day of the bone and joint week, which celebrates the birth of the Indian Orthopedic Association on the 4th of August. And, I'd like to take this opportunity to particularly thank Mr. Shrikant Ramachandran, who is a good friend of mine, Dr. Suresh Menon for his lovely introduction, the ex-head of the Novartis, and Mr. Satya, who is admin of this Spectrum Group. About myself, I train in UK in all aspects of orthopedics and trauma. I have specialist interest in computer-assisted robotic knee hip surgery, patient-specific implants, for which I did a General Medical Council of the UK recognized fellowship at Plymouth Teaching Hospitals, a specialist interest in hip and knee sports and revision surgery, which is redo surgery when something is not done properly or when things wear out. Did a fellowship in Avon Orthopedic Center, Bristol for this. And I have a particular passion for septic revision, that is infected revision. And my center provides a quarterly referral service for India. And I trained with Prof. GIRFT and Endo Clinic doing this very difficult 4 to 6 hours surgeries. Proud to have done my UG and PG from Bangalore Medical College Research Center, Premier Institute in Karnataka and India, Bangalore. I was a National Merit Scholar throughout right from my 10th standard onwards. I bring the experience of more than 12,000 joint replacement surgery over 14 years in the UK. And particularly blessed to have worked in 4 out of the 5 specialist orthopedic units in the UK, which is rare for any trainee in the UK, because these centers are centers of excellence, and they have infection rate less than 0.3%, which is very, very less compared to other peripheral hospitals, even in the UK. So working in these places is an amazing experience, once in a lifetime kind of experience. My objective is to provide affordable but high quality knee and hip replacement service in Bangalore, Karnataka, and India. Mark the word, the high quality is very, very close to my heart. Experience relevant to this topic, I trained in UK in all aspects of orthopedic trauma, special interest, as I mentioned, in computer-assisted robotic knee hip surgery, patient-specific implants, did a GMC recognized fellowship at Plymouth Teaching Hospitals in 2011, a decade ago. This is presentation of the fellowship by Dr. Jonathan Keenan, Director of Orthoplasty, and my boss at the Plymouth Teaching Hospitals. This is certificate from the GMC for its recognition of the fellowship. This is recognition, because of my passion for knee surgery, I was nicknamed Shri the Knee. This is my second fellowship, with Dr. Everett Smith, UK Head of European Hip Society at Bristol, and with Mr. Anthony Ward, Director of Pelvic Vestibular Surgery in the southwest of UK. This is our first sprayer approach, which is a minimally invasive approach for hip replacement done in India a few years ago at All India Institute of Medical Science by myself and Mr. Everett Smith. And on the right-hand side, you see a picture of the inaugural Meet the Masters course, which I organize as an annual event in some October, November every year. Here, Dr. Everett Smith is in Lee Meridian, and I'm flanked by my teachers of orthopedics, Professor J.K. Reddy and Professor Purushottam. This is my third fellowship at Endo Clinic, with Prof. GIRFT, who, along with Dr. Javed Parvezi of US, are world authorities on single-stage revision. And they're one of the few surgeons who do septic revision, that is, take the infected implant out and put a new implant in the same setting. These are complex procedures lasting from 3 to 5 to 6 hours, and it's not for the inexperienced. You need to be trained to be doing this. Very proud to have worked with immediate past president of British Knee Society, Dr. Richard Parkinson, who was my mentor. He was president of BAS 2014 to 2016, and he was voted top 10 best replacement surgeons and teachers in the UK. In fact, my first job was with him. And straight, I started doing revision knee replacement right in 1999-2000, when even a primary knee replacement was very rare phenomena in Bangalore at that time. Coming to today's topic, knee and hip arthritis. Arthritis affects around 20 million patients in India, almost close to 1 in 5. And I think around 25% of them would need some sort of surgical intervention at some point in their life. There's a big skill shortage in India. We know through the recent pandemic that we had only one doctor in 1,700 patients. So every trained and untrained surgeon is at knee and hip replacement surgery. In computer-assisted surgery, we have a saying that garbage in is garbage out. So if we feed the robot garbage, then the output of the robot will be garbage. And one of the basic tenets of orthoplasty, that's joint repair surgery, is if you fail to prepare, you prepare to fail. This is the outcome of an untrained person doing a joint replacement surgery, hip replacement surgery. You can see this. This is a couple of days post-op where there's a central fracture dislocation of the hip, which is put in. And who really wants this? As a patient, as a hospital owner, as a CEO, as somebody who's appointing your consultants, do you really want this? So now we have this Draconian Consumer Protection Act 2019, where a patient can comfortably sue a hospital or a doctor from the comfort of his home, just with the click of a button. There's no upper limit on the compensation, and up to 10 crores have been given. And very unfortunately, the patient doesn't have to go to the city where he was operated, can stay in a remote part of India like Malda or Assam and sue, and the doctor has to run all the way to Assam or Malda to face the suit. So this concept is, earning thousands for the surgery by cutting corners but losing crores. Coming to the knee, knee is called as a complex three-dimensional hinge. It is not as simple, hinge joint like a door hinge, which moves in one plane, but it can also rotate. So just imagine a door which can not only open and close, but also rotate. You can just see how complex the mechanism is. So when a patient comes to you with a knee pain, you really ask the age of the patient, was there any trauma involved, where is the pain located, if the symptoms start suddenly or over the course of time. Once they're investigated and putting the symptoms with the signs together, which is what you find in examination, you often reach a diagnosis. So the basic key points in knee is pain while walking down the stairs is due to kneecap problems, such as chondromalacia, softening of the patella. Morning pain and stiffness, which ease with time, is typically of early arthritis. Sharp pain with clicking, locking is commonly due to the cartilage damage like meniscal pathology or a kneecap problem or a loose fragment in the joint. The sudden pop associated with swelling and knee giving way, particularly young people playing sports, is indicative of cruciate ligament injury, ACL or PCL or PLC, and they can be reconstructed by substituting with autologous or synthetic ligaments. Arthritis of the knee can occur in a rheumatoid arthritis, can occur as isolated arthritis of the knee. These are the basic investigations done, like some blood test X-rays for the knee problem. The treatment options in principle same for the knee and the hip. You go with an analgesic ladder, which is a well-established ladder. Start from basic painkillers to advanced one. Everything fails, try intraarticular injections with corticosteroids. PRP, which is platelet-rich plasma, has come back in a big way in the last 7 years. Using artificial synthetic synovial fluid called Synvisc or Viscosil is a very interesting thing. I published a paper on this in the European Journal of Knee Surgery, a randomized controlled trial, which is quite rare in orthopedics. And stem cells have increasingly been used in the last 1.5 to 2 years as good evidence is coming up. These injections can be repeated a few times in a year. Treatment of OA of the knee or hip is, the role of physiotherapy is important because they improve both the mobility and the musculature and prevent sarcopenia, which is weakening of the muscle. Newer US FDA approved products like offloader knee brace, very useful. Pain shield, which is an electrical kind of stimulation to reduce pain. And pulse electromagnetic treatment can help. I think Srikanth deals with some of this, and he's probably a better person than me to talk about that. This is a very important slide. Let's look at the effect of the COVID on the arthritic patient. COVID Delta is a new type of COVID where there is no fever, there's no cough. The patient typically presents with joint pain and malaise, just like a dengue or chikungunya. Arthritis leads to less movement, that leads to osteoporosis or weakening of the bones, which leads to a hip fracture. And if a person undergoes hip fracture, particularly when he is very mobile, hip replacement is the right treatment, not a half hip replacement, which is very commonly done in India. Now, COVID lockdown can lead to can't go for a walk, worsens arthritis, increases obesity, which is a big problem. A lot of people are undergoing bariatric surgery for this now, even children, and also worsens osteoporosis. So, use the muscle or lose it to sarcopenia. A study in the West looking at the quality of life, being bedbound is worse than death for many of the Western patients. So, proper protocols, with proper protocols, even during the peak of pandemic last year, my professor Gurkha in Endo Clinic kept the COVID infections to zero, even after having done 5,000 knee and hip replacement surgery at the peak of the last year's pandemic in Europe. Let's look at type of non-knee replacement surgeries. So basically, this involves a keyhole surgery, which is arthroscopy, putting a scope inside a camera in the knee, looking at the meniscus. If it's damaged, just trim it or repair it. If there is damage to the cartilage of the femur or tibia, you can drill holes called microfracture. If there's a cartilage loss there, around a centimeter, then you can take good cartilage from a non-weight bearing area, fill it up like cigarette packs called Wurtz grafting. And you can also culture cartilage from these areas and grow in a petri dish and put it there in 6 to 8 weeks time, called ACL, MACI, that's cartilage transplantation. As I mentioned, damaged ligaments, ACL, PCL, and PLC can be reconstructed. The indication for knee replacement surgery are mainly osteoarthritis, 96%, inflammatory arthritis like rheumatoid, 3%, post-traumatic arthritis, less than 1%. Average age is 67, female has slightly more preponderance than male. What are the types of knee replacement? You don't need to do always a full knee replacement surgery. The knee has 3 compartments, medial, lateral, and patellofemoral compartment. Whichever damaged compartment can be replaced with a medial uni, lateral uni, or patellofemoral replacement. So I've been doing this procedure for 15, 20 years. This has become very popular in India in the last 4 years, particularly in the last 2 years, where the companies are pushing the unis in a big way. Coming to total knee replacement, what's new? Computer-assisted or navigated or robotic or a 3D augmented surgery is new. They all lead to predictable accuracy, make surgery safe, recordable, and prepares better surgeons of tomorrow. Providing transparency and accountability in medical practice is quite important, anywhere in the world, but particularly in India. They all act like a patient-specific implant because we now know in the last 4 or 5 years that not all knees are the same. If there are 50, 60 people in this meeting, all of us have a different, unique sort of footprint to our knee because of our genetics. Knee represent quick picture of how a knee looks. When you see, and this is a picture of a post-robotic surgery knee. And when I moved to India from UK, there were many common myths and practice, and let me go through some of them. Myth number 1 was that eyeballing was better than computer navigation robotics. Okay, you ask your child or grandchild, they will tell you that computers and robotics are more accurate than eyeballing. One size fits all. As I mentioned, the truth is every knee is unique. And you need to look at that particular knee and address the issue, not give same shoes for every person. Bilateral knee, doing simultaneous bilateral knee replacements are better than staged procedures. Dr. Javed Parvezi, the authority, published in 2007 a meta-analysis looking at 50,000 patients who had bilateral simultaneous, that is single sitting knee replacement, and showed that incidence of DVT, PE, that is clot from your leg, and MI and death was twice in a bilateral group compared to a unilateral group where the knee replacement was staged 3 to 6 months apart. Recently, a surgeon in India, a young surgeon, got suspended because while he was doing a simultaneous bilateral knee replacement, the patient died on the thing, and he was close to going to jail. So my suggestion to the junior doctors is, don't cut corners, put patients' interest before business needs. as I mentioned, you may earn in lakhs, but you will lose in crores. And if you or your CEO thinks that you are very clever business people, then somebody who loses in crores by earning in lakhs is not a clever business tycoon. He's quite silly. So, and looking at X-ray and doing a knee replacement is basically giving a two-dimensional solution for a problem. Our knee is a three-dimensional problem. We need to give a three-dimensional solution. And robot I've seen that gives 1 millimeter accuracy, and no surgeon has such accuracy, including myself. The common myth in India too is that anybody can do a knee or hip replacement surgery. Here you see a picture on the left of monkey doing knee replacement surgery. My UK trainees registrars thought the same thing. They said, Mr. Srikanth, no great thing about doing knee, open the joint, put the jigs, cut the bone, bang the implant in, close it up. Big deal, what's the? So yeah, unfortunately, even the corporate CEOs in India, particularly Bangalore, they think the same thing. They go by what is called EBDTS, earning before deduction of tax and other expenses. It is pay less, earn more. So unfortunately, the Supreme Court poured cold water on them a couple of days ago when they said that these EBITDA practice should stop, and you can't pay the Ayush doctors less compared to MBBS doctors and run your cardiac ICUs, etc., etc. So now they're in a dilemma. Do we still adopt quacks and employ quacks and Ayush doctors, or do we employ MBBS doctors and now the pay has become equal? So that's something they really need to think hard and long. So why did my registrar thought that knee replacement were a very, very simple operation, a bony operation? So let's look at Dr. John Insull, the father of knee replacement surgery in the world, at Hospital of Specialist Surgery, US. He called knee replacement as a soft tissue operation with some bony cuts. Why did he say so? When all the people, including the CEOs, are saying that it's a bony operation, because he understood the role of ligaments in the knee. Let's look at the role of ligaments in the knee. If you look at the knee, the primary restraint to anterior movement of the leg bone, the tibia on the thigh bone, femur, is the anterior cruciate ligament, but this is also prevented by the medial and lateral collateral ligaments on the sides of the knee. So like this, if you go through all the different movements that the knee has, it is controlled by not one ligament, but multiple ligaments. Some of the functions we understand, some of their functions we don't understand as of this day. If you look at the knee has got 6 degrees of freedom. That's why it's called complex three-dimensional hinge. If you look at the top left picture, the knee in bending, the flexion, can move sideways. It can rotate. In the bottom picture there, when you're standing on the middle top picture, it can rotate while standing. It can compress, distract, or the last two pictures where it can roll down like a ball sliding on a slide, or it can just bend along a hinge or as a transepithelial axis. So it's got 6 degrees of movement. And we need basic 3 cuts to do a knee replacement. A cut on the tibia, leg bone, femur, thigh bone, and the patella, which is kneecap. The permutation combination, 3 cuts and 6 degrees of freedom. An experienced joint replacement surgeon can get a knee replacement wrong in 215 ways. What to speak of an inexperienced person who has just passed his MS and said, I'm a specialist joint replacement surgeon? So I've given a real answer to the common myth in India. A clear no if you have patient interest at your heart. Primum non nocere. That is, first do no harm is a basic and first principle of medical ethics. So proper training and experience is a must. So the modern concepts of navigation, PSI, patient-specific implants, and robotics are coming. You know why he is the best the world has? Because you can measure what he has done. I don't know if he's running today or tomorrow in the present Olympics in Japan. So there are a number of limitations in the human eye. Eyeballing can't differentiate less than 10 degrees of change in angulation. But just more than 6 degrees of change in angulation, that is what we call varus valgus, in the knee alignment, can lead to catastrophic failure of the joint replacement surgery. You don't want a bad day at office to affect the outcome of your patient surgery. You want to minimize surgeon errors when so many factors are at play, some known and many unknown, like the role of the ligaments. And 1 millimeter accuracy is humanly impossible unless you employ a robot. So there are need for the patient-specific implants, computer navigation surgery, robotics, or 3D augmented surgery. There are varieties of them. I'll not go into the details. And this is a very important slide which showed why things change. Earlier, we thought that the knee moved like a door hinge, a 2-dimensional hinge. Then they moved on to J-shaped kinematics, more complex concept. Now we believe that they, either it moves along the transeptal axis, which is the yellow line here. Most surgeons believe that, and then they put the knee parallel to that. But those who believe in 3D knees, they minority, around 20% in the world, they put it along the trans-cylindrical axis, which is the green line here. And you can see there's much difference between the green and the yellow line. So that makes a difference whether 20% patients were dissatisfied following a knee replacement surgery, even done by an expert who believes in the trans-epicondylar line. So what is this advanced technologies? What is shape matching? You get an orthotic model and a planning model. And then you get, a custom-made femoral and tibial cutting guides are machined to match the virtual plan of the knee and to position the femoral and tibial components in all the 6 degrees of freedom that is mentioned. So all these technologies, PSI, that is robotics, CAS, that is computer surgery, 3D augmented surgery, follow the same basic principle. That is, you do the surgery virtually before you actually do the surgery on the patient. That's why accuracy comes. This is my first robotic surgery picture on the left-hand side. I started robotics in Bangalore last year. We adopt the same principles. It gives really, as I said, 1 millimeter accuracy. The bone cuts are done taking all the 6 degrees of freedom into account. And it actually leads to less soft tissue dissection because of precision that robot brings, leading to less painkillers need post-op and less blood loss, because you dissect less soft tissues, and hence you don't need to give extra blood transfusion to the patients. And this is the graft I got in the very first, robotic knee replacement surgery. And this is after the implant was put in, the final implant was put in. And you can see the graph on the bottom, which is a straight line. And, the patient had early rehabilitation and early discharge also compared to the older manual knee replacement surgery. Dr. Kaper, who's the creator of this robotics, should be very proud of this flat line that I obtained in the bottom, which shows a perfect soft tissue balance in the whole range of movement from 0 degrees of knee to 130 degrees of bending. And the opening on both the sides was just 1 millimeter, in the varus and valgus. So this is a first time, in the history of joint replacement surgery, we are getting objective evidence of the soft tissue balance. Always it was subjective. I said, my knee was more stable than yours. And he said, no, his knee was more stable than mine. But here is objective evidence to show that, yes, it is stable. It is just opening up 1 millimeter on both the sides through the range of movement of that particular knee. So this is incredible. So there's a post-op picture of the same patient. And now future, as they say, is now this is a patient-specific implant that's compressive robotic surgery. Benefits, as I said, is less tissue cut, less pain, less blood loss, and faster rehabilitation. And the goal is to get what is called a forgotten knee. That is, once the knee is done, the patient should not feel that it's an arterial joint, which they still feel now in 2021. So the take-home message is, who should be really doing a totally replacement? That's the question we need to ask, and choose a surgeon carefully, looking at the time for the operation. Check if he's fellowship trained in joint surgery and where. Ask him about his results and complications in art literature, and don't trust everybody. Use online resources to make your due diligence. Proof of the pudding by Indian experience. I don't know if Srikanth may remember this. This is in a hospital which was just started 2-3 weeks in Banshankari in Bangalore. And this is the first computer-assisted knee surgery we performed for this hospital. The lady was an obese lady, and she could get 90 degrees knee bend first day post-surgery. This is a surgery done in a corporate hospital where there's just 2 hours post knee replacement. I just finished writing the notes, went to the recovery to see this lady who was already lifting the operated knee straight. And many surgeons, my colleagues in Bombay, which Srikanth knows very well, make these patients walk, and some are even made to dance a couple of weeks later, called as a dancing knee replacement. They do Garba or something, and that is used to market quite well by some of my colleagues in Mumbai, which Srikanth is quite well aware of. Now, coming to complex cases, differentiating the men from the boys, the Indian experience. This is a 60-year-old lady, 120 kg diabetic. She was operated by the top 2 joint replacement surgeons of Karnataka. Unfortunately, the knee got infected. The senior surgeon went ahead, did 5 more surgeries, and then everything failed, so he gave up. So he left her with no joint, and she was in a bedridden state for nearly 2 years. And her daughter came to me 2 years post event and said, Dr. Srikanth, can you help? And I said, this is my training in Germany and UK, so let's see what can be done. This is how she came initially on the left-hand side, the primary complex primary knee she had, and on the right-hand side, that's how she came to me with no joint. The issues that she had was morbid obesity, diabetes mellitus. She had 5 failed surgeries. She had multiple scars. You can see her marked in blue pen. And on the last surgery, the senior surgeon was not able to close the knee. So he asked his plastic surgical colleague to help him, who would come and use the gastrocnemius muscle, one of the heads, to cover the knee. And I knew that if I needed a plastics cover, I have only one more head of the gastrocnemius left to cover. And shortening, which I'm showing there, the left leg was 1 inch shorter than the right leg. And she needed a bariatric table and a bold anesthetist. So I aspirated the knee and I grew E. coli, a bug, planned for a 2-stage revision here, put antibiotic-loaded cement spacer. The inflammatory markers, ESR, CRP, came back to normal in 8 weeks. So the second stage issues were which hospital to do, teamwork. It was a combined orthopedic and plastic surgical teamwork. I had to get clearance for this patient from a senior physician, nephrologist, cardiologist, vascular surgeon, senior anesthetist, and all were little apprehensive. Dr. Srikanth is new to India and he's doing this complex work, how things will go, how we will be caught up. So these are all their worries, but always they get reassured when now when I come to their theater. So the second surgery, the challenges were the type of anesthesia. It was a prolonged surgery, as I said, between 4 to 5 hours. And that's why, here only, the juniors can run out of steam after 2 hours of doing surgery. So unless you're trained, don't go for these surgeries. That's what I tell you. And then there's massive fluid shift. And she rightly went to ICU for a day and then got discharged to the ward. The quality of quadriceps, there is a muscle in the thigh was poor, which was also addressed at the same time. So after many more challenges, I got an X-ray like this, and I got her to walk like this. This is the most important thing, People think doctors operate for money. It's not for money to operate, but she could walk up to 2.5 years of the state. So coming to the second example, this is a 50-year-old lady. She had not walked for 2 years again. She was literally carried by her son, in the hands into my center. So seen by the senior Prof Iyer, who is a professor to my professor in Bangalore. He had said, God help you. One of the orthopedic surgeons aspirated the knee, that is taken samples of, and it had grown nothing. She came with 90 degrees fixed flexion. That is, the knee was stuck at 90 degrees, had not moved. I got an MRI which showed complete destruction and of the joint, plus from hip to knee to ankle. So I planned for stage revision, opened the joint, removed all the pus, do the radical debridement, put a cement space with antibiotic there, and sent for literally all investigations. I had sent to Hyderabad, and all investigation came negative. But fortunately, during my training, I was always taught to send some sample for histopathology. It went to my friend, Dr. Prasad, who was a histopathologist. He called me next day, said, Srikanth, this is the classic TB. So I started on ATT, and the patients were not very affordable. You could see the paper thin quality of the bone there. So they said, please don't put an expensive revision implant, which cost 2.5 to 3 lakhs. So we did a Jugadu surgery. I customized this nail from Gujarat from a local company, Atmanirbhar Bharat, and put this, and with ATT for 6 months, the knee went on to fuse. So briefly about the hip, I'm going to talk about the painful hip, the role of hip arthroscopy in delaying THR, patient-specific for custom-made hip replacement, and the latest hot topic, the spine-pelvic hip axis. Where does the hip pain go? Typically to the groin, or superficial groin or deep groin, the lateral side of the thigh. The hip problem can also cause you back pain, or it can cause knee pain, strangely. Typical investigations are X-rays, epilateral, but increasingly we are doing sitting and standing spine X-rays with the hips. MR and CT is useful, and hip block injection is also useful. The treatment is typically rest and non-steroidal the painkillers as per analysis, ladder, weight loss, physio, ultrasound guided injection. Hip arthroscopy is a keyhole surgery where you can debride the soft tissues called labrum and prolong the life of the joint, or the last but not the least is the hip replacement surgery. Looking at the hip replacement surgery, the latest hot topic in the field of orthoplasty is this spine pelvis hip axis. So here is a picture from the UK. So this is done recently, a couple of years ago, by a consultant, not a trainee or a junior surgeon. And on the left-hand side in the X-ray, you see a perfectly done hip. It is perfect. You can't do a better job than that. But in the middle picture, you see the perfectly done hip dislocated. Okay. So what was missed here? was that the patient has a stiff spine. And although this guy was a 5-year-old consultant, he missed a stiff spine and the hip dislocated, then he had to do a revision surgery. So unless one understands this complex relationship between spine, pelvis, and hip surgery, even a perfectly looking surgery always fails. I was speaking to Professor Ed Davis, who is a professor of robotics in Royal Orthopaedic Hospital, Birmingham, just around 4 or 5 weeks ago. I asked Prof, Ed, can you just tell me, demystify this relationship of the spine to pelvis to hip? And he said, Shri, I can't, and this is where things are. And, when a professor of orthopedic surgery who's been doing robotic surgery of the hip for a year says that, how can an untrained person, always claim that we are doing a perfect total hip replacement? So, no amount of due diligence is less in getting things spot on. So you need to examine spine and the hip and the knee to make sure the patients get good outcome. This is a second example. Okay, simple is not easy and easy is not always good. So this is a hip replacement uncemented, what we call done again a couple of years ago in the UK. So although the X-ray looks perfect or the X-ray looks good, it was successfully litigated in the UK because the patient felt that the right leg was 2 centimeters longer than the left leg. This happened because a simple varus neck, which is a shortened neck shaft angle on the left side, is normally 127 degrees, but here it's 122. It was missed by the surgeon, and he used an uncemented implant, which goes where it goes, but you can't reproduce the anatomy. So, and hence, this is a very popular implant in India because it is quick, it is easy. It costs more money for the implant patient and more money for the company. So they try to promote that, and then younger surgeons think simple is easy, and easy is always good. But as I mentioned again, you can earn lakhs, but you can lose in course, and it's not a clever real policy. So what is the solution to this? The solution is a cemented hip replacement. This is a gold standard, and you can really control all the parameters of the hip doing this. This technique is almost lost in India. Not many people are doing it. That is a very important solution to these problems. So OPS is an optimal cushioning system, which Srikanth will start using it by the end of this year. Is a very useful thing to avoid this. Robotics definitely is useful, and the custom hips are useful. There's a custom hip called the Symbiosis hip. You get a pre-op 3D CT, and then we get an exact fit anatomic THR, and leads to better functional result and longer life. To conclude, I would like to say the Southeast Specialty Orthopedic Center offers the best the world has in joint replacement surgery, knee and hip replacement, and fusion surgery. A patient, that is your safety, is at the heart of the care, which is the most important thing, which differentiates us from the rest. And truly international standards is provided, and the team is trained by the European Hip Society President and the British Knee Society President. And in short, I would say that you experience Europe in Bangalore and India now. So I thank you very much for the patient listening. I really like this quote of Aristotle that we are what we repeatedly do. So excellence is therefore not an act, but a habit. And these are the references from my talk. And this is details about me, my number, PRO's number, my website, srikanthpn.com, through which you can book appointments. And I really seek your support to serve these patients better. Thank you very much. I welcome any questions you've got.